Welcome everyone to the International Conference on Integrated Care. I'm sure you've either seen other sessions or are familiar with the conference already, day 2. So let's dive in. This is session 8.1, Better Outcomes for All. We have 6 pretty incredible speakers today, and all women, which is a great session today, a female-dominated session. I think we could probably just dive in. I'd like to remind everyone, please ask questions in the chat room. I will try to moderate them as best as I can. And yes, if you could keep your microphones off, please, while people are presenting, that's very helpful always. That's it. I think we should dive in. So our first speaker, Dr. Kristina Rosengren from Sweden. Since everyone can see the titles and you know, of the sessions, I'm not going to do big introductions to the session or the speakers because you can all read them yourselves. So welcome, Kristina, and you can take it away. Is she here? I don't see Kristina. I think, Darren, I think this is one of the recorded videos, right?
Hello, my name is Kristina Rosengren. I'm an associate professor at the University of Gothenburg in Sweden, and I'm very honored to be here and present some of my a study that I have done with some colleagues about innovation and diffusion of person-centered care. So I work at the Institute of Health and Care Sciences at Sahlgrenska Academy in the University of Gothenburg, and I'm a nurse as a profession, and I work part-time at the university and part-time at the Sahlgrenska University Hospital in an internal medicine department with the research and the quality improvement, and some education as well. This is my research area. I'm a registered nurse, as I told you, and I'm an associate professor, and my area is organization, leadership, working environment, and quality improvement, and I will talk about person-centered care in an organization perspective. And I'm also one of the researchers in GPCC, a network of researchers in person-centered care, where I conduct this research. So this is the background for my research, and me and my colleague would like to look at the European perspective. How implemented is person-centered care in Europe? So our research was built on interviews, a lot of interviews in 26 different countries, and the background was that we would like to see if the organization and the financing aspects are significant, and how they involve or influence diffusion of person-centered care on macro level to identify facilitators and hinder. So that was the background of our research, and the aim of this study was to describe facilitators and barriers in terms of regulation and financing of healthcare due to the implementation and use of person-centered care in different European countries. And we have a qualitative content analysis with a deductive approach based on the innovation theory. So we use the strategic sample with staff working in healthcare in Europe. First, the staff was first-line manager, hospital manager, officials, and researchers. And we did a lot of semi-structured interviews, 68 and it was 25 male and 43 females, and 21 was based on the hospital level, 21 on hospital management level, and 26 on the national board or research level. So we catch in micro, meso, and macro level. And it was 27 countries involved, and we grouped them due to their healthcare system. So beverage, it was 15 countries: Denmark, England, Finland, Iceland, Italy, Latvia, Malta, Northern Ireland, Norway, Portugal, Republic of Ireland, Scotland, Spain, Sweden, and Wales. And the Bismarck health system was 11. It was Belgium, Czech Republic, Estonia, France, Germany, Hungary, Netherlands, Poland, Serbia, Slovenia, and Switzerland. And also one who had a mixed health care system, it was Greece. So we have a question due to healthcare financial system. We would like to know the policy documents regarding PCC, and we also would like the roadmap for PCC in relation to the innovation theory that include knowledge, persuasion, decision, implementation, and confirmation of PCC. And we started all the interviews with an open-ended question. If I say person-centered care, what are your thoughts about that subject? And then we have the follow-up interview questions. And all the interviews variation time was between 30 and 60 minutes and was recorded and transcribed verbatim. And the data analysis was qualitative content analysis, and we read it repeatedly to have an overview of the participants' experience. Thereafter, we add the healthcare system and diffusion of theory as our glasses, and we use this used to look at similarities and differences regarding participant statements that was described. And it was about implementation of PCC, stated control of healthcare, knowledge, persuasion, decision, implementation, and confirmation. That was the innovation theory that we used. And this is an overview of the results in the article. Due to this innovation theory's 5 themes. And then we talk about facilitators and hinder in implementation of person-centered care in Europe. And I would like you to recommend you to look at this article that was published this year, 2023, in Journal of Health Organization and Management. And the result was that countries such as Great Britain and Scandinavian countries, this was a beverage tax-based healthcare system, were inclined to implement and use person-centered care in a structural way, and the freedom of relative freedom of market that was the grounded in Bismarck and mixed methods healthcare system did not seem to nurture demands for PCC compared to beverage countries. So there was a difference due to the healthcare system. And in country with an autocratic culture, that is high power distance, such as Mediterranean countries, PCC was regarded as foreign and not applicable. Another reason for difficulties with PCC was the tendency for corruption that hinder equity and promote innovativity in the healthcare system. So our conclusion of this result was that in countries with an autocratic culture, that is a high power distance, such as the Mediterranean country, PCC was regarded as foreign and not applied. And another was corruption, as I said before. So the implementation of this research is that the sample of 2 to 3 participants divided on micro, meso, and macro level for each included country was problematic. We have 68 interviews, so it was a lot, so it was not possible to include more than 2 to 3 participants per country, but this could be tricky to draw conclusion on the country level due to the limited number of participants. So we would like to have, and also we only have 27 countries included. So this is also problematic to do conclusion due to diffusion of person-centered care in Europe. So the results should be should be considered due to this limitation, due to the number of participants per country, and also that only 27 out of 49 European countries was included. So therefore, there is a limitation due to the results. But this is the first study that we have coming across due to these different levels of healthcare, micro, meso, and macro level. There is studies on the micro level and also on the macro level, but it's not on the all levels together as this study. So the conclusion is that support at the managerial level, together with patients' rights, supported by European countries' law, facilitate diffusion of person-centered care, and the fragmented healthcare system divided by separate policies, document, or managerial roadmap hinder local and regional policies, where it's difficult therefore it's difficult to implement person-centered care. And support at managerial level, together with patient rights, facilitate diffusion of person-centered care, and that's why there was differences due to beverage countries that are tax financed compared to Bismarck and mixed methods. And this is a picture that could visualize this conclusion due to person-centered care and public control. So if you have a high degree of public control, and then you also get a high degree of person-centered care. If you have low degree of public control, then you also have low degree of person-centeredness or person-centered care. So this was my presentation, and I hope that you enjoy it and have some ideas of how diffusion of person-centered care could be done in your country. And if you have any questions, please email me, and I'll be happy to answer it, and also read the article. As you see the references on the top of these slides. So thank you, and have a nice conferences.
We thank Kristina for her presentation, a very ambitious study looking at the 3 levels of care in 27 European countries. That's quite a feat. If she were here, I wanted to ask her, in her opinion, she was in the abstract also, I read that one of the conclusions is that in states where there are fragmented health systems, person-centered care is not present or is at a low level. So I wonder which came first. It's kind of the chicken and the egg. Which should we develop first, the person-centered care or an integrated health system? And I think this is a good question for everyone. Right, so let's move on. I realized I didn't even introduce myself when I started the session. My name is Nereide Curreri. I know you read that as well in the abstracts. I'm so happy to chair this wonderful session, and please post any questions. So our next speaker was also unavailable, and oh, I just saw Ivy's comment. It's very interesting to see the relationship between public control and person-centeredness. Yes, totally agree. Can seem counterintuitive. Yeah, yes, very interesting. And I'd love to take that up at the end of the session, perhaps, if you'd be willing, Ivy. Right, so the next speaker, Frances Barraclough, is going to show her presentation, her video presentation on workforce development.
Hi everyone, my name's Frances and I'm presenting today on workforce development in integrated care, the development of an international framework. I'm a senior lecturer and the academic coordinator for interdisciplinary education at the University of Sydney. I'm recording today from beautiful Bundjalung country in northern New South Wales on the east coast of Australia. I'd like to acknowledge and pay my respects to elders past and present from our Bundjalung country. The presentation today will include gaining an understanding of the iterative process behind the development of this international framework. I'll talk briefly about what are some of the barriers and challenges to implementing workforce development in integrated care. We'll talk about what some of the models of training are and describe what are the key components of this framework. So who's involved in this study? This study is part of my PhD. As I mentioned earlier, I'm a senior lecturer for the University of Sydney, and I actually teach a whole range of different disciplines and students from other universities as well. I'm very, very passionate about my integrated care and about informing students and our future and current health workforce. So this is part of my PhD, and I'd like to acknowledge my supervisors, Professor Jennifer Smith-Mary, Dr. Sabrina Pitt, and Professor Victoria Steen. So why do we need an international framework? Although the literature contains many examples and programs of workforce training in integrated care across different settings, there's insufficient evidence of a global framework to guide this education and training requirements to provide this type of care. So the development of the framework started off with a systematic scoping review. So I had a look at the international literature and I found a list of around 31 competencies and different themes and key features of education and training specific to integrated care. This systematic scoping review was published in 2021, if anyone would like to see it, in the International Journal for Integrated Care. The next part of my study was looking at a modified Delphi study, looking at discussing with global panelists or experts with experience in delivering education and training in integrated care, or those that have conducted research in this field. So I did 2 rounds of a Delphi study just to try and see, ask the participants to list the competencies of priority and highest importance to see if there were any competencies that were missing, and to also look at what the key themes that came through about integrated care. The next round of the development of the framework involves consultation with health consumers and carers on the implementation and design of the framework, followed by consultation with professional bodies and organisation to guide the implementation. So just to map that out again, so this is an exploratory multi-step design. The study involves the scoping review, the modified Delphi study with key experts to further develop the framework, consultation with consumers and carers, and consultation with key professional bodies on how we can apply it. So, with the scoping review, it was carried out in April-May 2020, looking at a number of key databases, and they're listed there. The articles were included if they described any education model or framework and key elements or competencies in health workforce training. Articles were excluded if they had a single disease focus, were conference abstracts, or there were no full texts available in English. And you can see there that the literature, I was able to look at 62 records. So in that scoping review, it really highlights to us what some of the barriers, and I'm sure that for you, those of you who are listening who are involved in teaching, training, develop competencies for integrated care, that you understand that the curricula for healthcare workers do not promote experience and skills in community and integrated care settings. So students learn about primary care principles in many training programs and curricula, but then they're placed in clinical environments where it's difficult to implement and practice those principles. And I experienced that myself with the health disciplines that I teach. So the students are often placed in acute care settings. There's limited access to experts. This also inhibits the scaling up of the existing competencies and curricula. Faculty expertise, organisational and other logistical factors are other recognised barriers. Training still emphasises the diagnosis and treatment of acute diseases. It's fragmented and outdated. And the education and practice focuses on component elements of an issue or a disease. There's rigid separation of disciplines at the educational level. We're still learning in silos, fragmented learning and practice. There's the focus on disease treatment without considering the daily life of our people, our patients, and the existence of comorbidities. There's still an emphasis on using standardised pathways and specialists who do not fully understand and are able to facilitate a patient's journey and pathway through the whole system. Employers and organisations have limited understanding of integrated care. So some of the models and training recommendations that's come up through the scoping review and the Delphi study, so important to involve people with lived experience in the design, delivery and evaluation of our training. Embed opportunities for collaboration and learning across disciplines, but across service providers. Create an environment where there's a willingness to think differently and work together. Implement policies for new staff in organisations, such as providing integrated care manuals and shadowing opportunities for placement with our referral organisations and service providers. Incorporate integrated care concepts organically throughout our curriculum, so it's fundamental to delivering care. Simulation-based scenarios, consider using actors from our communities, but those actors should have lived experience. Interprofessional skill development across our faculty to update our curriculums in line with these changes. This is just a slide showing, after the scoping review, I carried out a Delphi study, and this is the 4-step process, and you can see there the reference to the literature, the paper by Nasser about how I carried out this process. So once I conducted the scoping review, or our team did, we systematically identified gaps in the literature and current knowledge. I then consulted with a panel of experts from around the world with experience in delivering and developing training in integrated care. These experts came from the literature, from the scoping review, so the authors of those key papers, also help from the International Foundation on Integrated Care, snowballing, so asking others who are leaders in this field. So we developed a survey and administered 2 rounds of the Delphi study to identify what are the priority competencies, themes, and these to identify training models. So this helped guide and further develop the International Competency Framework. So the domains that came out of the Delphi study, and this paper is still not published yet. I'm still doing some analysis on it, but the key domains are related to person-centered care, interprofessional teamwork and collaborative practice, care coordination skills. A domain that was added following from the scoping review was the importance of our workforce having digital skills in digital and technology, health promotion and disease prevention, population health, having leadership in this field, and also professional skills and ethical attributes, looking at diversity, inclusion, and social equity. Thinking about the competencies, these stood out for me following on the Delphi study, improving our individual people's and carers' knowledge and their skills and confidence to navigate the health and social care system. Collaborate with not only service providers within the acute primary, but also consider our informal care settings. More about that care coordination role, the importance of engaging patients and families through technology-based communication tools. Also, thinking about our providing education on self-care strategies and developing leaders and future role models and clinical or local champions to reform and guide change in integrated care. So to finish with, our future workforce needs to understand the national, state and local systems and be willing to challenge and negotiate how healthcare is provided. They need to manage a patient's health and care rather than disease and cure, have digital literacy, know and understand our community's needs. There's a couple of references there. The first one is to the scoping review that was published, and the second one is the guiding paper that was used for the scoping review. And if anyone has any questions, you can see my email there. And I'm also part of the Senior Associate group for the International Foundation of Integrated Care. Thank you.
Thank you so much to Frances, and hello to Frances. We met through the Emerging Researchers and Professionals in Integrated Care. Fantastic group. If anyone is interested, please look them up. They're part of the foundation. Very interesting presentation. I just wanted to say all of the domains that she mentioned are actually being spoken about today in the presentations, which is really interesting. The barriers I just found so relevant across various nations. And then I did have a question for Frances that maybe I'll email her. I was really interested in because of the slow uptake of integrated care and person-centered care, as was mentioned in the previous presentation, how transferable is this framework in other contexts, and how we can include the contextual appropriateness and cultural appropriateness within these frameworks of training. So anyway, if anyone has any comments or solutions to that, I'd be happy to read them. So Ivy is very active in the chat. Thanks so much, Ivy, and we'll definitely get to that at the end. We'll have a great discussion, I'm sure. Our next presenter, Dr. Samantha Spanos, will speak to us about epilepsy and integrated care in epilepsy. So the floor is yours, Samantha.
Hello, great to be with you online today. My name is Samantha Spanos and I'm from the Australian Institute of Health Innovation at Macquarie University, Sydney, Australia. Today I'll be talking to you about integrated care in epilepsy with a specific focus on the implementation progress in this field. Epilepsy is the most common neurological condition affecting 50 million people worldwide of all ages, genders, and socioeconomic backgrounds. Epilepsy is associated with significant physical, psychological, and psychosocial impact even for people who live seizure-free through using anti-seizure medication, because these drugs often come with significant adverse effects. People living with epilepsy require ongoing health and social care, and the National Institute for Health and Care Excellence recommends providing coordinated care and the involvement of multidisciplinary teams to provide ongoing care across the lifespan for people living with epilepsy. Despite these and other guidelines, epilepsy services remain fragmented. Health and social care systems lack standardisation and formalised clinical pathways in epilepsy. And there's quite a bit of ambiguity and misconceptions among healthcare providers around their roles and responsibilities in epilepsy care. And of course, this can significantly impact referral times, access to targeted treatments, and the care experience. We know that integrating epilepsy services across sectors can support holistic and person-centred care provision for the specific health and wellbeing needs of people living with epilepsy. There are quite a few diverse approaches to integrated person-centred care in health across health and social care sectors, but it's unclear what the core components of integrated care are, as well as their uptake and implementation in models. So that's what we looked at in the scoping review. We looked in the literature for the components and models of integrated care that have been recommended or implemented in epilepsy management. And we went beyond just a descriptive approach to look at the extent to which evidence-based components have been incorporated within models and the challenges associated with implementation. We conducted 3 searches over the past 3 years across 4 databases, articles that had epilepsy as a key focus and that described an integrated care approach. We extracted data on care components and models, as well as whether they were recommended or implemented, and synthesized data into themed components and broad areas that these components fell into. And then we identified the uptake of components across models. 36 studies were included in this review, and as you can see, the majority were published in the last 5 years. What we found were 15 components of integrated care aligned with 4 broad areas. The first area, healthcare staff and pathways, included multidisciplinary teams, and they're of varying structure and roles, cross-sector collaboration across health, social care, community, education and voluntary sectors, clinical practice guidelines and care pathways across a variety of settings, epilepsy nurses, usually involved in organising services and providing psychosocial care. The second area was tasks and services, and this included psychosocial services, care coordination services, care management plans for seizure management and broader care goals, transition services from paediatric to adult epilepsy, and surgical evaluation for people living with complex epilepsy who may be eligible for brain surgery. The third area was clinical and information technology, and the components included were shared electronic medical records to facilitate information exchange across services and sectors, telehealth services, and digital health tools, including clinical decision aids to support healthcare professionals, as well as self-management tools for consumers. The fourth area was education and engagement, and included in this area was shared decision-making between healthcare professionals, people living with epilepsy and their families, person-centred education, and education for healthcare professionals, particularly in primary and community settings to support ongoing management, as well as education focused on shared care. And these components were either implemented or recommended as standalone components or within a model of care. We identified 12 models of integrated care in the literature that were comprised of various combinations of components. 7 of these were implemented models, and they were primarily from Ireland, also from the USA, Australia, and the UK. And 5 of the models were recommended, and they were primarily from the UK, also from Ireland and the USA. So here are the models again, and I'm not going to focus on individual models and their components, although you can get that information from our manuscript if you would like to. But rather, I'm going to look at the extent of uptake of the components across the models. Here are the evidence-based components that we found. And no single model implemented or recommended captured all components. Across all models as a whole, 14 of 15 components were captured. Surgical evaluation was the only component that wasn't included in a model. Now focusing just on implemented models, 12 of 15 components were captured. Transition services and digital health tools were included in recommended models, but not in implemented models. So we've looked across models to see whether or not components were captured, but now let's look at the extent to which components have been implemented. Most components had high implementation. They were included in more than half of the implemented models. But there were also components that had low implementation despite their strong evidence base. And here are some of the reasons why. For clinical practice guidelines and care pathways, there was limited training opportunities for healthcare professionals on how to use these pathways, which can lead to the lack of knowledge that they even exist. And also lack of motivation was reported as a barrier to implementation of guidelines and pathways. Epilepsy nurses lack well-defined roles within multidisciplinary teams and models of care, as well as having an undefined scope of practice, which might be contributing to under-implementation. With transition services, epilepsy services have been conceptualized primarily as binary, either pediatric or adult services, rather than focusing on an age continuum. And surgical evaluation has only been considered as and recommended as a standalone component rather than conceptualized as within a model of care. Digital health tools are rapidly emerging, and potentially uncertainty about how to implement them can lead to late adoption of including them in models. And education for healthcare professionals has remained focused within acute care settings and also hasn't had a focus on shared care goals. We've identified some of the implementation gaps, but there's also some sustainability challenges associated with the components that have high implementation across models. Interprofessional collaboration and coordination relies on continuous and appropriate education and skills development for healthcare professionals, support for communication processes and structures that can get around perceptions of clinical autonomy or territorialism that exist within professions. And it also relies on funding models that incentivize integration. Electronic record systems need to be integrated and compatible as they upgrade. So this is something that needs to happen in order for healthcare professionals to be able to share knowledge with each other and exchange information. And person-centered care and education really relies on adequate staffing as well as workplace cultures that foster compassionate care delivery. So sustainability needs to be considered alongside implementation of epilepsy, integrated care services in epilepsy. And our analysis of core components has highlighted that national, so country-specific clinical practice guidelines and care pathways for epilepsy services need to be co-developed with people living with epilepsy and evaluated with trained healthcare professionals. The role of epilepsy nurses must be articulated and better understood, as well as the barriers and facilitators to implementing transition services, surgical evaluation, and digital health tools within models of care. And key to the sustainability of integrated care is education and training for healthcare professionals, which needs to be collaborative, cross-sectoral, based on common goals, and with a greater focus on building capacity in primary and community settings. A big theme in the literature, a major theme in the literature, was that we really need a whole system approach to integrated care. That includes governance structures, policy and funding systems that support shared priorities and shared benefits across systems and sectors. This was the first project to look at the breadth and type of components of integrated care in epilepsy, and contributes a 15-component blueprint for assessing the comprehensiveness of integrated care models. But some of the limitations about, when we looked at articles, we looked at their context specificity, but we need to really look at implementation determinants across systems to inform the translatability of models, as well as their eventual scale up. Another important thing to consider is the factors associated with integrated care for underrepresented communities and diverse communities. So we are able to highlight some of the systemic barriers to accessing care, and in order to address inequalities in care delivery. Thank you.
Thank you so much, Samantha. I think you're here with us. I see your icon. I don't know if you can. Hi, thank you so much.
Hi.
That was a fantastic study. I specialize in dementia, and I saw quite a few parallels with dementia.
Yeah, right.
So very interesting. Your last comment about looking at the determinants of implementation, and I want to add and of sustainability. I really appreciate that. And the sustainability of our models. Yeah, do you want to talk more about that?
It's sort of a dual challenge, isn't it? I think actually there's quite a bit of research at the institute I work, Australian Institute of Health Innovation, looking at the factors that can impede or facilitate sustainable interventions, because that's really what's going to keep them there. And things like funding run out, you know, so that's a big one. But
often the number one, yeah.
right, yeah.
So I just came to my mind talking about funding. I did research for my PhD in Central America, and so contexts with fewer resources than maybe we are used to in the northern and Australia's not so north, but the developed, I hate to say it, or the minority world countries. Yeah.
Sure.
Can you see maybe models being more creative about resources instead of we kind of, I don't know if we need funding, but are we also scapegoating funding as our problem too?
Yeah, no, that's a really important point that I think a lot of people would have something to contribute to. I think it starts with finding a consistent way to research like these barriers and factors across systems, to understand what they are, so that we know whether funding really is the one that is the most important one.
Yeah.
But I'm not the best person to speak to about, as I pointed out in one of the limitations was we didn't really explore that, and that's something that's really incredibly important. So I'd love to hear more about your work too that you did.
Oh, thanks. I had one more question, if you're willing.
Sure.
You mentioned some models that you found in the UK, the US, Ireland, and a few in Australia. And just getting back to the international context, do you think, I mean, how closely, well, of course, these are all Anglo-Saxon countries, so perhaps the models are quite transferable to Australia, for example, or did you find, because you did find the gaps, but are you thinking of looking at more contextual, cultural gaps as well, or?
Absolutely. But I think something really that's an area that needs to be further tapped into is the recommended models that haven't yet been implemented. So there's quite a few really nice models, like hub and spoke type models that I think that have been implemented for other conditions that I think could be sort of adapted. So looking at the flexibility and adaptability of models that have been recommended for other conditions or implemented for other conditions, and looking at how they can be sort of reworked rather than reinventing the wheel. And then exploring the contextual factors around that. I think that might be a good place to start.
That is a wonderful idea. So we'll wait for next year's presentation on on this bit of research.
Yes, absolutely.
Well, thank you so much again, and hopefully we'll have more to discuss at the end of the session.
Yeah, absolutely. Thank you.
Great. Thanks again, Samantha. Okay, our next speaker is Ms. Paula Pinto Araya, and a very interesting topic for all of us, one that is not spoken about enough, is death and pride in death. I love that title. So Paula is here with us. Yes, so there you are.
Here. Hi, hello.
Great. Hello.
My broadband though has been on and off today, so I do think the presentation, recorded presentation might be best, but I'm here for the Q&A just because it hasn't been steady.
Great. Well, here it goes. Thanks so much.
Great. Good afternoon, everyone, and thank you for joining me. My name is Paula Pinto Araya, and I'm Program Manager at All Ireland Institute of Hospice and Palliative Care. And I'm very excited to be here and share with you Pride in Death, an LGBTQIA+ Death Cafe. So how did the Death Cafe get started? All Ireland Institute of Hospice and Palliative Care carries out an annual public awareness campaign during the month of September. And we do this because palliative care is still a very misunderstood concept that is generally associated with end of life and cancer only. However, palliative care is much more than just end of life and much more than just cancer. It's for a plethora of life-limiting conditions. And that's why during the week we try to promote conversations around advanced care planning, death, dying, and bereavement, because a lot of people who could be availing of the services are not, which means they're missing out on better quality of life. And research shows that 43% of people agree that if they had to have palliative care, they do not have enough information to make those decisions or to have conversations. So we thought, if these are the natural struggles that the general public has in terms of accessing palliative care, what are the specific struggles, if any, that the LGBTQIA+ community is having? And that's when we reached out to LGBT Ireland. And while there's not a lot of specific research in relation to LGBTQIA+ community and palliative care, there is general research around health. And that does show that the community, for example, 42% have experienced poor quality of service due to their identity, and that only 48% of the community has discussed their final wishes. And so we reached out again to another partner called Irish Hospice Foundation that carry out advanced care planning through their thinking ahead strategy. And research shows that when we talk about our desires, our needs, and our wants for end of life, there's different benefits for everyone, such as enhanced hope, sense of control, improved quality of life, lower readmission and ICU rates. And actually all these benefits are enhanced for the LGBTQIA+ community because it ensures that their identity is not erased and that their dignity remains intact at all stages of life. With thinking ahead, the community can ensure that they receive the care that they want, that their chosen family is around throughout all stages, and that their identity is respected. So that's when we decided to have a community-focused conversation. In other words, a death cafe. And we started planning, and the partners that came together was LGBT+ Ireland, Irish Hospice Foundation, Liz Gleason, Director of Shapes of Grief, Bettina Korn from HSC End of Life Care Coordinator at St. James's Hospital, and the All Ireland Institute of Hospice and Palliative Care. So that's when the Death Cafe became Pride in Death. And we were thinking about the different elements that we needed to consider. And one of the most important ones was creating a welcoming environment, because we knew we were going to be having difficult conversations that could cause stress and anxiety. So we chose Pearse Library, which is located in the city center of Dublin. And it's a community space. It has lots of natural light. It's welcoming, but it has privacy. We didn't want to overwhelm with a lot of flags, but we did have beautiful natural flowers to add color. We had images of queer icons who had died to ensure we were also setting up the right atmosphere. We had tissues, we had a quiet zone. And then we started planning in terms of the actual conversations that we were going to have. And we talked a lot about structured facilitation, having videos and stories to ensure people had a reason to speak and conversations could flow. We thought about having small breakout rooms and interactive elements. We thought a lot about different ways of ensuring conversation flowed. And then on the actual day, as mentioned, we anticipated people would be afraid or anxious, but actually people were really engaged and talkative and very relaxed. We thought there would be a need to fill time, but again, what happened is we went over time, and after going over for a full hour, we had to bring the event to a natural closure. We also thought that there would be more men than women and non-binary people. However, there was gender diversity. We thought there would be more older people showing up at the event, but there was age diversity. And we anticipated that there would be primarily white Irish. And this was the only thing we anticipated correctly. So the main takeaways that came from the Death Cafe, and I'll just note that while the first Death Cafe was in September of last year during Palliative Care Week, because it was such a huge success, we actually had an additional Death Cafe in February of this year. So this is a main takeaways from both Death Cafes. So there was a need noted regarding having specific LGBTQIA+ bereavement support groups, because these currently do not exist. And because the community suffers from ambiguous and complicated grief due to a variety of issues specific to LGBTQIA+. So a way to tackle this is a partnership between the Irish Hospice Foundation's bereavement support line and LGBT Ireland bringing in training. There was a talk about intergenerational networks. So there was assumption that older people who are generally more isolated are the ones who want more connection. But on the day, it was actually noticed that it was reciprocal. People want to connect, people of all ages, and they want the safe spaces to have that. Another outcome was the LGBTQIA+ end-of-life reference group, and the fact that we need to have the community at the heart giving feedback when we are developing resources for members of the public, for example, for the Palliative Care Week campaign, and when we were developing resources for healthcare staff. Early gatekeeping. This was a term coined by James O'Hagan from LGBT Ireland, and it refers to that final stage in life, the funerals that tend to be raptured up around religious rituals. That means that LGBTQIA+ identity is lost. And so that there's a need to create more creative engagement, creativity for funeral planning outside of religious rituals, so you can ensure that your identity is respected till the very end, and that your queer family is around for that stage as well. There was also the need for the LGBTQIA+ nursing homes, a specific one where they can keep their identity intact, where there's a safe space so they can make their own traditions. And finally, as I mentioned before, everyone was adamant about having more events. So we had one in February, and now we're having our third one during Pride in June. The date is yet to be confirmed. And finally, the main conclusion from all the Death Cafes, and while everything wasn't specific to palliative care, there's so much learning and such fruitful learnings from it. But at the end of the day, it's about talking to each other, listening to each other, and learning from each other. Thank you so much.
Thank you so much, Paula. So motivating, just beautiful. I'm just thrilled about this study and these events. And my question, by the way, pearly gatekeeping is fabulous. Can I use the term?
Yes, I think James will be very happy if it expands.
Ivy, would you like to speak with the microphone? We'd love to have your input.
Yeah,
there she is.
Absolutely. Thank you, Paula. Such a cool presentation. And we have found in work that we have done on long-term care that queer folks sometimes feel that they have to go back into the closet when they come into care. And it's not just vis-a-vis the other residents, but sometimes the caregivers, not often, but sometimes. And so such a great initiative, and really, really happy to bring that back to colleagues here. So really wanted to thank you for that.
No, thank you. And that's definitely something that kept coming up about that, their identity being lost at the end because of this situation. And that's why they don't want to access the services, because it means having to go back in the closet after a lifetime of trying to come out. So
important.
Yeah, thanks so much, Ivy. Paula, I had a few notes first about the name. We, dementia is dementia cafes and creates so much stigma. So I'm wondering, and going back to Samantha's presentation as well about creating models. This is definitely a model that we would like to, I would love to, and Ivy says, let's bring it to, her colleagues as well. We want to use this as a model or create a model. I don't know if you want to touch on both aspects, the stigma of the name, and which has, the pro and cons, because let's talk about it openly, but on the other hand, does it?
I suppose there's a stigma of just death cafes on their own, because when I first reached out to James at LGBT Ireland, he's like, what's this? People are already uncomfortable just by the word death. And although death cafes are actually quite an international movement, they've been around for a while now, they're still not as well known anyway. So there was that first sort of stigma and barrier to become over. But then there was the fact of it's specific per community. In this case, it was LGBTQIA+. And so that's when James thought of the name Pride in Death, which I thought was perfect. And we do put Pride in Death, a death cafe. But I don't know, it's that thing of that, I guess, when you put it into context and the different people have been going and people leave so energized, and it's just word of mouth eventually. Like, people want this in Cork now. We're definitely having one in Dublin because there's that need of connection. So it's just normalizing it as well, that conversation around death. As much as we talk about life, we could talk about death, and it doesn't have to be so hard, or anxious or create stress.
Yeah, absolutely. I'm thinking about a framework perhaps, or a sort of model. We'd love to see something that we can copy, translate into our various
We're
countries.
talking about that as well, because it's at the moment, the four of us are the facilitators, and we're not enough to carry out through Ireland, for example. So we are thinking about, there's been a few people who came to the first Death Cafe, who came to the second, and they themselves are very eloquent and articulate, and it's their own experience. So we're thinking how we can make them the champions, and then they can lead on, and it's community led. So you wouldn't need us anymore, So yeah, that's definitely something we're working on.
Well, it's beautiful. Thank you so much for sharing. And that's definitely part of the integrated care. In fact, another question was, how can we, and I asked this to everyone, although we should have the other speakers go first, but how can we incorporate something like this, a death cafe, into our pathways, into our care pathways?
I was thinking about it in terms of the social prescribing. There's a bit of work happening at the Institute on that, and sort of really, I think, placing more value on these community networks. Even these sort of like groups that help you recover from substance abuse, or just any kind of connection. I think this would be incredible, and really keeping the care in the community.
Yeah. In the various communities, at the various levels, micro, meso, macro communities. Yeah.
Absolutely.
Well, thank you again so much, Paula, and perhaps we'll continue the discussion at the end of the session. See how much time we have. Right, so on to our next speaker. We have Keriin Katsaros. I'm not sure if I'm pronouncing it correctly. I'm thinking it's Greek, but it's possibly Irish.
Very Greek.
It's very Greek, okay. And she will speak to us about settings. This is very interesting about settings. We were talking about contexts and now settings. So all yours, Keriin, thank you.
Thank you. And I will present live today. Let me just share my screen. There we go. So thank you for the welcome. My name is Keriin Katsaros, and I'm presenting today on behalf of the International Network of Health Promoting Hospitals. And I'm the coordinator of our secretariat, working together with Dr. Oliver Gröner, who's the CEO. Before I start on the main presentation, I just want to give you a brief overview of the international network. We refer to ourselves as the HPH network. It's a little bit shorter, but the HPH network was initiated in the late 1980s by the World Health Organization, and we were founded on the settings approach to health promotion, specifically with hospitals, and we later adopted health services as well. And our network, we work to support members to incorporate health promotion concepts, values, and frameworks into the governance and the management structures, cultures, and operations of hospitals and health services. And our overall aim is to ensure that hospitals and health services maximize health and equity outcomes for everybody who comes in contact with this setting. That's, of course, patients, but also staff, communities, populations, and the environment. You'll see here, oops, no, you don't see here. Now you see here. We have just under 600 members, and we represent currently 35 countries. This number is constantly growing. We now have a member in Africa, which you don't see on the map. We will have to update that. So to operationalize the vision and mission of HPH, our network created standards and implementation tools for hospitals and health services. There are 5 overarching standards in this standard set. You'll see them listed 1 through 5 on the left hand of your screen. There's 18 substandards and then 86 total standard statements. And the 86 standard statements in these standard sets represent over 30 years of experience in the implementation of health promotion. So we used all of the knowledge that we have within our network to develop these standards. They also reflect the work of various task forces and working groups that we have. For example, we had a task force on equity, mental health, the environment, health literacy, patient-centered care, and then with certain age groups such as children and adolescents and also the elderly. Since we published these standards in 2020, our members and networks have translated them into 11 languages, and those are all available for free on our website. At the end of the presentation, I will put up the web address so you can have a look at those in more detail if you'd like. So how can these standards be used in an integrated care system, and why are they important? This settings approach is holistic, and it encourages the full transformation of the healthcare organization into a health promoting setting. And at the core of this, we have collaboration, engagement, and partnership. Both the standards and the 9 pillars of integrated care share the same values and goals, and that's to increase health outcomes for all. This is especially relevant now when we're moving into this post-COVID era. A shift towards these values is really needed in order to reduce the workforce burnout that we're seeing and improve leadership, to promote collaboration, engagement, and partnership. So in this presentation, I will briefly introduce each of the 5 overarching standards, and show how implementing them into the hospital and health service setting supports the values of integrated care. There we are. So standard 1, actually, before I begin, I just want to say that none of the standards or the pillars of integrated care that I have here are mutually exclusive to each other. There's a lot of overlap. What we've done here in this presentation, we're just going to show the most obvious examples. So you'll see standard 1 at the top is demonstrating organizational commitment for HPH. And then there's 3 substandards. You'll see them listed right under that. So the leadership, policy, monitoring, implementation, and evaluation. And this implementing standard 1 focuses on management. So do we have the right policies in place, and are they implemented, are they lived, and are they lived by the leadership in the organization? In order for changes to be made, management has to be on board with that. Policies that are implemented also need to be flexible. They have to be adaptive. And the leader of the organization needs to recognize that the organization is actually part of a larger system. So moving away from this siloed approach to thinking and implementing policies that encourage collaboration both within and outside of the hospital and health service setting. So we also, I said earlier, we developed implementation tools. And basically with these tools, we can see, has this standard been implemented? And how do we know? So you'll see in the green box, we have indicators. Those were taken directly from the implementation tool that we developed. So just an example, one standard that we have in standard 1, do the actions of our organization's leadership team mirror the aims of HPH? So do they mirror the aims of a health promoting hospital or health services? And to evaluate that, you would look at a work plan or some type of an action plan. So we'll move on to standard 2, ensuring access to the service. Standard 2 focuses on supporting equality and equal access to services, regardless of an immigration status, the insurance that you have, health literacy levels, your language, socioeconomic status, impairments, and disabilities. The standards focus on viewing all community members as equal. So for example, do you have your website in local languages, or do you offer some type of translation service so that the community members accessing your health service or hospital have the same standard of care? In terms of integrated care, this might also mean utilizing some type of a network that's already available within a community. So taking an asset-based approach. This might be a church or some type of a cultural center, or maybe even a death cafe, as we heard about in the last presentation. Another example of a standard within standard 2, or our organization develops written material and navigational signs considering health literacy, language, cognitive abilities, and patient groups. So it really is about transforming this setting into an area where everybody has the same opportunities and access to the services that the organization provides. So moving on, standard 3, enhancing people-centered care. This standard probably has the most overlapping concepts with integrated care. It really embodies the same core competencies that you see in an integrated care model. There's a focus on creating partnerships and engagement. And this, of course, is not just engagement with the patient, but also with their families, with the community, and with other care providers along a care pathway. The standards in Standard 3 ensure that patients have the right information in a way that they can understand it, and so that they can make their own decisions and use tools provided by the community to better their own health. So in practice, this might look like providing culturally appropriate material or age-appropriate material for children, for example. The staff also need to be trained on how to speak with children in an appropriate way. Discharge letters have to be understood by the people they're given to. The next standard, creating a healthy workplace and a healthy setting. This standard is especially important. Implementing this standard is important, especially we've seen the stretched workforce that a lot of institutions have experienced due to COVID, stressed mental health needs. So it places an important focus on moving past this in the post-COVID period. On the last, or Standard 3, I spoke about patients needing to work together with staff, but the staff also needs to know how to work together with patients and also their families and entire care teams. And in order to do that, the staff has to be both mentally and physically prepared to do so. So examples of that, do we provide some type of needs assessment for staff during especially stressful times? The health promotion approach, we say, is comprehensive, but we can't forget that includes everybody, including the people working within the setting. So our last standard, promoting health in the wider society. This recognizes that a hospital or a health service is much more than just the physical building. It's part of a larger community. There's also effects on the environment and on the community and the very diverse people living within it. Give and take from both sides there. So just some examples what that might look like. We work with we work with public health organizations to collect information on disease prevention and health promotion needs in the catchment area. It also incorporates services for disadvantaged populations in the community, and then of course the reduction of fossil energy and the use of renewable energy sources. So thank you so much for allowing us to present. What this presentation really concentrated on was, I remember when I first learned about integrated care, it was very overwhelming, and I said, well, how do we do this? Using these standards, hospitals and health services can take very small steps to becoming a health promoting setting. And I hope this presentation has shown how health promoting settings and organizations that support health promoting are also very capable of being part of integrated care systems. It can be used as just a first step. So if you have any more questions, or if you'd like to download the standards, the website's there, as well as our email address, and we will look forward to hearing from you. Thank you.
Thank you so much, Keriin. That was very interesting. And I have to say that I really appreciated how you incorporated the pillars of integrated care, and how it was very helpful to see how in 5 standards you can incorporate so much of the integrated care models. And also, I saw a lot of dementia in there as well, dementia design and dementia friendliness. Of course, that's kind of my lens, so I see that everywhere. I had one question which I may have missed in a few of the slides. is how you have a health promoting hospital or health center, and how do then you link them to each other. That's kind of more system level. You know, you create this health promoting center, and then how do they link together? Is that part of one of the standards, or is that extra?
Well, this developing relationships to the community, we don't actually like give concrete ways to do this, because it's always dependent on the national or regional context. So it looks different depending on what country is implementing it. We have just developed an online platform for our members that they can post good practices of what a implemented standard might look like. The idea is that people can be inspired from what happened in a country across the globe, but I can't say exactly what it looks like because it's always different.
That's an excellent point. Yes, it's definitely context-based. Thank you so much, Keriin. If anyone has any questions, please post them. I don't want to take any more time as we're nearing the end of the session, and we have Ivy Bourgault. I think you pronounce it Bourgault. My poor French. Who is our final speaker for today on team primary care. So all to you, Ivy.
Thank you so much. Yes, and I'm very pleased to be presenting on our initiative, Team Primary Care Training for Transformation. As is customary in Canada, we acknowledge territory where we are coming from. I am situated in the capital city, Ottawa, otherwise known as Ottawa, which is the unceded, unsurrendered territory of the Algonquin Anishinaabe First Nation people, for whom I give thanks for the ability to live, work, and play on this jurisdiction. I want to acknowledge our team lead. So this is our coordination team: Ivy Anderson, myself, Ivy Bourgault, Jasper Sinner, Dale McMurchie, and Lisa Manganero. So if we talk first about why team primary care, and first of all, we highlight how it's a timely opportunity to transform training. And these are sort of situated three steps. So we have a crisis in access to primary care in Canada. There are estimated 6 million Canadians out of our population of less than 40 million who do not have access to a regular primary care provider, whether that be a family physician, nurse practitioner, or a team of providers. 1 in 6 family physicians are nearing retirement. Now, so the government's challenge is, do they just produce more family physicians? And that is not going to be a sustainable solution. It's definitely not short term. So teamwork in primary care is one of the solutions to help stabilize and sustain our healthcare system. It also recognizes all of the other folks who are doing work, all of the different practitioner groups that are doing work in primary care. And so we're kind of inspired by a royal commission that was undertaken over 20 years ago, Roy Romano, that said, if healthcare providers are expected to work together, it makes sense that their education and training should prepare them for this type of work arrangement. Now, we have not been able to deliver on that, which is the reason why team primary care. So our overarching goal is to enhance the capacity of interprofessional, comprehensive primary care practitioners, particularly working in teams. So we need to enhance capacity to meet growing population health needs. We want to do this through improved training, improved retention, and planning tools. And we want to, while we are in the process of aligning and retraining, reforming training, we want to embed the principles of interprofessionalism, equity, diversity, inclusion, and accessibility, psychological health and safety, reconciliation in the spirit of Indigenous reconciliation, and social accountability. So our vision is enhanced readiness of a supported primary care workforce to deliver more team-based comprehensive services with greater continuity and coordination of care with a whole person orientation. So that's our vision. And so on the next slide, we put that at the top. And here is our workforce solutions framework to deliver on that vision. So we are taking, different steps that we first want to identify and align the different comprehensive primary care services and workforce that's needed. We want to increase the number. Once we've included everybody, we want to increase their number of practitioners, particularly working in a team-based approach with everybody's different scopes recognized and optimized. We want to enhance the flexibility and adaptability of the comprehensive primary care workforce for different settings. And we have a particular theme looking at rural and remote, as well as Indigenous health services. We want to increase supports for those different comprehensive primary care practitioners working in teams. And throughout this, we want to embed the principles of interprofessionalism, equity, diversity, inclusion, accessibility, psychological health and safety, and reconciliation, all towards there being greater social accountability. So that's embedded into these activities. And then we have created different team primary care tables that address each of these different steps in an open and collaborative way. We have the interprofessional collaborative table, team optimization table, a cross-cutting supports table, and our Indigenous advisory circle. And I'll talk about each of these in detail. So first, our IP collaborative table is really focused on training enhancement and alignment to strengthen the foundations for aligned comprehensive training for team-based care. We have created a forum to share and align curricula, as well as to embed and enhance the competencies, the principle-based competencies. And so really the collaborative is there to support the different training programs, to convene and curate different resources to align, spread, and scale. Out of a number of activities, we've talked about these being the critically important elements in the design of aligned training. So fostering relationship building and sharing of promising practices, tools, methodologies across disciplines, identifying the range of services included in comprehensive primary care, what we call sort of a basket of services, to promote greater breadth and alignment in training. We want to integrate the development of interprofessional competencies into training. So those are distinct from competencies in delivering comprehensive primary care. We want to ensure training is informed by our team primary care principles. We want to understand the scope of practice, the skills and roles that various primary care practitioners have or could have in order to maximize individual and collective delivery of services. And also to develop organizational culture, leadership, and processes that support change and create environments that build relationships, in part flattening hierarchies and enabling effective teamwork. So pictured here are the different project training partners who are at the table. Those around the circle have a funded project as part of our initiative, but there are others who are at the interprofessional collaborative table as full partners, not necessarily with funded projects. And in addition to the ones that we see around the table, we will be including oral health practitioners shortly. So you can see that there's a range, and particularly of some groups where they focus, like family practice nurses, family practice pharmacists. So not all of nursing, not all of pharmacy, but those really focused on primary care. So this is an unprecedented, inclusive approach. We also have a team optimization table, which is to create a community of practice, advancing team training. So, continuing professional development type of training to support more optimal delivery of comprehensive team-based primary care. So again, we are creating a forum to embed those principles and for different teams to share lessons learned and how they go about problem solving, what we highlighted on the slides previously. Now, we did have a call for funding, and so this is the range of projects. We did encourage participants to have a specific focus on equity deserving population. So you'll see that there's a lot focused on internationally educated health practitioners, Indigenous health practitioners, transgender populations, but just to see that it's, coast to coast to coast. And we do have some projects that are national in scope in partnership with the Society of rural physicians and practice eligible routes for added competency, particularly in rural settings. What is supporting all of these different training programs and teams is a cross-cutting team, which is to help us to embed the principles in comprehensive primary care training. And so this is a way that we are gathering those resources, gathering the leading practices so that the different teams and training programs don't have to go and find all of this by themselves. It will be easy to access, and we will be supporting that with team primary care webinars. We also have embedded into this initiative both principle-focused developmental evaluation as well as the objectives, outputs, and outcomes evaluation, which is required by our funding partner. And then we have a meta-evaluation. So each of the teams, each of the training programs has a developmental evaluator to support them and really kind of guide them in that process. So this is team primary care in one very busy slide, but it goes through our vision, our different activities, the principles in the middle, our different tables, and then with the hope that we'll have these types of outputs. So primary care training aligned and scalable across 20+ health professions, 18+ team training initiatives that are scalable, which are focused on equity serving populations, retention planning and team resources for training and employers. And here are some of the outputs in terms of the number of rural practitioners trained, internationally educated health practitioners who are supported in their pathway to optimize their roles, hundreds of Indigenous healers engaged and supported, as well as different practitioners across all of those different practitioner groups. Curricular developed, including micro-credentials where there are gaps. So just to acknowledge our various project sponsors, our project co-leads, of which I am representing the Canadian Health Workforce Network. This is just some of our project partners. We are updating our slide as our partnerships develop. So we have over 65 partnerships at the start, and that's growing. So for more information and comments and questions, please feel free to follow us at TPC ESP in French. Team Primary Care is our website, and these are the email addresses for all of us, and I'm looking forward to engaging with you in questions. So thanks.
Thank you so much, Ivy. Wow, I am so intrigued by the interprofessional competencies. I think this is just a key to integrated care, but just to working together. It's your quote of Romanov, we need to be trained to work together. How absurd is that? We need to be trained to work together. It's, as you said, counterintuitive about
no, absolutely. And you know, so I think that there have been really important interprofessional training initiatives. I think that those need to be really embedded and scaled and spread much more widely. And to train interprofessional competencies, you need to do more than just tell people. You need to have them practice it. And one of the things that I highlighted at the top of the program is we do not have sufficient interprofessional training opportunities. So for different, practitioners, and particularly in primary care, many are focused on interprofessional practice opportunities in hospitals. That's easier to arrange than in primary care. So we really need to have the training and the interprofessional practice opportunities. And that is over and above competencies in primary care. Again, comprehensive primary care competencies, and then you need the interprofessional competencies on top of that.
Yeah, absolutely. The intersectoral. It's interprofessional, and then you have the various levels of that as well.
Absolutely.
Just fascinating. And yes, I would love to get updates on all of these presentations, these fantastic studies. And that's huge. That's national. So
yeah, it's a big initiative. Yeah. It's very extensive, but a very short time frame. So we have to do some incredible amounts of work before the end of March 2024, which is when our funding is done. So we're being very mindful about how do we seed, spread, and scale change, and not just have all of this wonderful innovation disappear subsequently. So we're being very mindful about that.
Oh, that's interesting. That touches on Samantha's presentation. And also, I think there was definitely a connecting thread. And this I take from your abstract, I think, Ivy, that we need education to catalyze change. So yeah, so a lot of education, training. We are 1 minute over. You have all been fantastic. I am so honored to have presented this session. Just incredible work. Thank you all so very much, and hope to see you at the conference virtually. Best of luck with all your research. Thank you.
Thank you so much.
Thank you so much.
Thank you all.
Thank you.